The panel that we're going to be doing this afternoon is on prevention and recovery treatment programs. And I'm going to pass the mic down the road and let everybody introduce themselves.
I'm Dr. Morgan Birch. I'm with Grace Health. I'm a family practice physician here at our medical campus. We have treatment programs here at the medical campus with our women's clinic and then recently at our Hyden office.
I'm Tony Landrum. I work for Cumberland River Behavioral Health. I'm the director of Crossroads, which is a inpatient residential treatment center for men. We are now in London, Kentucky. Used to be in Corbin. We moved to London now.
And I'm your moderator. I'm Tim Cesario. I'm the Director of Recovery Services for Cumberland River Behavioral Health, your local community mental health center.
My name is Raymond Miles. I'm the Executive Director of Recovery Works in London, Kentucky, which is an inpatient residential addiction treatment center as well.
Yes, I'm Michael Abbott. I'm a LCSW LCADC representing Baptist Health, Corbin. We have all the levels of care except for residential.
All right, thanks everyone. So I'm just going to be reading through a list of questions for each of our moderators to answer. I know there was a request that we get done in about 30 minutes. I don't know for sure that I'm going to be able to accommodate that. So if anybody with Union comes, anybody from Union in here now? Great. If anybody comes in, we're going to have to stretch it out a little bit. Okay. All right. All right. So the first question for the panel is, what are some effective prevention strategies for addressing addiction in different age groups and demographics? I'm going to start off with Mike on this.
Yes. Well, I guess it was in 1995, the last time I implemented a prevention early intervention program, but it worked extremely well. It was Prime for Life, the under 21 version. Has anybody ever? Yeah. I love the program in that by the time the patients finished, they could really tell you the risk factors, that could set them up for addiction down the way. They all came into the program. They would ask me, or I had the first session would be, what type of person becomes an alcoholic or a drug addict? And other than the ones that would say my dad or my uncle, what do you think some of the responses would be? Weak will, lack morals, all these things that they weren't. So they thought it wouldn't happen to them. And that was my best feature of the program, was that they all did walk out knowing that could happen to anyone. I'm not that familiar with some of the other programs out there. I know it's a community approach, though, and the school system is where you have the captive audience. So that would be my answer there.
Thank you. Dr. Birch, I'm going to let you answer.
So the great thing about being a family practice provider is I get to see babies all the way to our elderly population. So doing those well child visits, we're going to be talking about drug and alcohol prevention. And then, it's in our clinic. We have patients that are there. So if we're not screening for them, then we're missing that population. So we do lots of screening, behavioral health screenings. And thankfully, we have an integrated care model that patients have access to multiple different providers, all that are willing to work and screen patients for that goal of recovery and prevention.
Thank you. Okay, next question. What are some signs or indicators that someone may be at risk for developing an addiction, and how can early intervention programs help address these risks?
Oh, that's a great question. Thinking about signs, I guess it's just probably going back to early age, when did the onset happen, that sort of thing. I would think would determine, whether or not one becomes addicted. Lifestyle, home life, that sort of thing, all plays a role in that. I don't do a lot of prevention work because I do work in residential treatment, but I would like to think that helping those gain recovery would help with prevention with the rest of the family. that sort of thing. So as far as prevention goes, that's about all I can add as far as prevention.
As Tony said, my current role is working with people that are currently experiencing the effects of the addiction. But previously, I have worked with adolescents, and I see in that with working with at-risk youth, a lot of it is the family factor, the family history. There's studies showing genetic factors as well, genetic predisposition to addiction, as well as the family connection there. So I saw that for all the programs I work with adolescents. And just what you see is what you get a lot of times, right? So a lot of the family sessions I did, for instance, when I did work for Baptist Health, we would do family sessions with those adolescents. And a lot of the times the issues they were experiencing and the reason they were on an adolescent psychiatric unit dealing with these issues where their parents were battling addiction. So, it just it was something that they saw, they knew that was what they were exposed to. So that exposure kind of led them down that path a lot of times. So, as was said, is starting as early as possible to let these adolescents know that they don't have to follow that same pathway that they're seeing. But it is difficult when that's what you know. So that would be really my response to that one.
Okay. Thank you.
One thing I would like to point out is one of the trickiest symptoms or risk factors is the developing tolerance. A lot of these young people who have the strong predisposition have a natural tolerance, and they think they can handle their alcohol better than their peers, which actually is, it fools them into believing that this ain't going to happen to me because look how much better I handle it than my peers. But that's one of the number one predicting factors.
Thank you very much. And I would like to add to that. I think one of the goals whenever you're working in a prevention program or working with kids at risk is to help them define a new normal, help them identify alternatives to use that, your life doesn't need to progress in the same way that you see at home, that there are options that don't include use. Just wanted to throw that in there. So how can communities work together to implement these strategies and reduce the risk factors associated with addiction? Already used your term.
Okay. I think a lot of it is reducing stigma, increasing access to care, especially in healthcare. We know we are working and striving to see this as a disease and a chronic illness and not necessarily something that people choose to do. And removing those barriers and increasing transportation and just networking. There's a lot of resources in the community that we just don't know about each other. I think that would really help in improve and having conferences like this, local conferences where we are made aware of what's available in the community to have more resources to take back to our patients and increase their availability to care.
Thank you. You sure?
As far as the community standpoint is exactly what she said. And unfortunately, there are a lot of programs out there that we just don't know about each other. But sitting in this room, I see multiple programs, and sometimes you get people that come from the perspective of competition, right? This is not a competition. We are trying to keep people alive, right? So it doesn't matter to me if they go to StepWorks or, addiction recovery care, wherever they go, if they're getting in a bed and getting treatment in any residential setting or any program, that means we're saving somebody's life, right? And that's what this disease of addiction is, the natural consequences of that, I say this all the time, is death, right? One way or the other. So we have to work together. We have to become a community, because if we don't, we have people that we're getting left behind. So these kind of events are important for that.
Good. Okay. All right. So how important is it for addiction treatment programs to address all aspects of addiction, physical, psychological, emotional, and social?
Very important. You have to have a holistic approach with these clients. And we try to do that at the treatment center. We try to meet them where they're at when they come in with any need they may have. And as they progress through the program, we try to do needs assessment things of that nature to help them gain the things they need to be successful in the recovery process. So as they transition through the programs, different levels, lengths of program, we're always trying to figure out and offer opportunities for them throughout the whole entire process. So I think holistic is extremely important. Without that, you're going to leave something out, which is going to lead them to have a deficit in the recovery process. So really important, yeah.
Yes, I think there was a one size fits all mentality for far too long. I love seeing now that programs are designed to address all the different factors that make us human. Also with the MAT, I was one of those that was drug into that kicking and screaming, but all the research backs it up that that's working on one part of the brain while the psychotherapy works on another, and blending those two have shown great success.
Just kind of add on to what Micah said. I had limited experience with MAT going into my role at Recovery Works, and I have seen that be very effective for a lot of people. We don't push that as a treatment option, but we offer it, right? We have different offerings, whether it's Suboxone, Vivitrol. We have some outside providers we work with on the methadone treatment as well. But you know, we have to look at each person individually and find out what's going on with that person, because you can't force a treatment on somebody that's not going to work for that person. So it is, and that's the tough part. A lot of times, just trying to dig in to see what's really going on. I know we've already talked today about the dual diagnosis, the co-occurring disorders, which came first, the addiction or the behavioral mental health issues. So, you know, and it is tough in our setting when we have them for a limited amount of time to really dig too deep, but you can at least kind of scratch the surface and see where they need to, what direction we can push them in from there to get the help they need.
Fortunately, as a healthcare provider, we are able to get a full history when we see a patient, and we've made it really a priority to meet patients where they are. We want patient-centered care, right? We can't do, you know, Maslow's hierarchy of needs. We can't expect to make any progress or headway on any chronic illness until we fix those problems. And then two, you know, when you come see me for addiction, you're not just getting addiction treatment. I'm going to do labs. We're treating hepatitis C. We're treating diabetes, high blood pressure. If you need vaccinations, we're going to do that. Any of the, you know, the mammograms, colonoscopies, it's not just one thing. So we're making sure that we're treating the person as a whole and not just the addiction.
Okay, I'm going to go off script for a minute. And I know there's probably about 10 people in here that said, oh God, what's he going to do? But I'm just going to, I knew he would. I'm just going to ask everybody up here, and how different is the field today from 10 years ago?
I think it's drastically different. Really, if we look at it, 2014 was a big year. That was the Affordable Care Act that identified drug and alcohol treatment as one of the 10 essential health needs. And it said to cover it insurance-wise like you would med-surg. We haven't quite got there, but we have seen 400,000 extra Kentucky residents with insurance that didn't have it before for the preventative care and all that they need, you know, to recover. I was in the field 15 years ago, and there was probably 5 residential programs statewide. Now we have, how many would you guess, Raymond? Yeah, a lot. Yeah. We rarely see somebody leave our detox unit without a bed if they want one. And that's tremendously different from when I started in the field.
From my perspective on that too, just I went to Recovery Works in London in 2019 from Baptist Health to there, working in their IOP program, transitioned to the clinical director at Recovery Works and been the executive director since 2021. And what I've seen from that time at that IOP program to where we're at now is the substances the potency of the substances, the effect of the substances people are using on, and their behaviors are so much different than what I saw just when I first moved into the field from the adolescent world. A lot of these people were looking at just almost like a TBI response, like, their impulsiveness, just the behavior we're seeing is so much different. And it has to have a direct correlation with the kind of substances they're using and the potency, as we talked about earlier, with the THC levels and all those kind of things. It definitely makes a difference in the effect on the brain and just in turn the behaviors.
I'll piggyback off of some that they've already said. I think one of the things I've seen in the past 24 years is just the sheer amount of services now that's offered, which is tremendous. I'm so glad to see that there are so many residential treatment centers now and other types of services out there. So that's a big change. And the substances, as you mentioned, thinking over the past years, these substances now are just deadly. They're just so much more potent than they used to be. So I think that's been a pretty dramatic change in the last 23 years or so that I've seen as well.
So coming out of residency about 10 years ago, addiction treatment wasn't a family practice issue. It was something that you referred over to behavioral health, referred to psychology. And now this is where treatment is family practice. It's in your primary care provider. And that's a huge change. And thankfully, Kentucky as a state has gone from being very regulated and who can write medicine and what the options are to now we want this in primary care, and there's funding for it, and there's education for providers if they want it. And that's changed addiction as a whole, just because those patients were already there. Now we just have education on how to help them and reach them when we didn't before.
I just had a couple of things to add to that. One is, it was about 10 years ago that licensure came into being for alcohol and drug counselors. Roughly 10 years ago, peer support started to be available. And I think those both play big factors are both big factors in how training and how treatment has improved over the last 10 years. I think it allows for more accountability on the practitioner's part, but the other part of it, which I think is even more important, is the peer supports that are working with them. I mean, for the first time you have somebody, because remember, counselors, you're not supposed to say, yes, I'm in recovery, only if it's for the client's benefit. But now we have that person working with the same clients that we're working with that are able to share their lived experience. And I think that's been a tremendous benefit that's only been available for the last 10 years. That's been a tremendous benefit to the people that we serve. Okay. So what are some best practices in holistic treatment programs? You threw holistic out there first, so I'm going to give it to you, Tony.
Best practice. That's a tough one. I really don't know. Curriculum wise, we try to use, best practices and things when we present material. Always looking for ways to improve, ways to do things better as far as best practices, but don't really have a lot of information as far as best practices. Oh, sure. Always meet the client where they're. I think I've already mentioned that. Certainly, you always got to meet the client where they're at.
It's like Tony had mentioned. Sometimes it is about the curriculum and using the evidence-based treatment. But we've made changes in our curriculum recently because we saw that initially we're kind of pushing college level information at people who may not be there. Right. They may not be at that point and they're still struggling. They're really fresh into the recovery process. And so we made changes in our own on even at a higher level all the way down through our company to, add some different types of activities, some more recreational activities to give that a little bit of break of just that constant information being bombarded in your brain when you're not really ready for that. So a lot of times it is, once again, meeting them where they're at and not, you have expectations of what you want people to achieve, but they may not be there, at that point yet. So.
Yeah, I just think having a toolbox with multiple tools is important. We definitely always use a combination of motivational interviewing with the CBT. I see a lot of folks with the trauma-informed care, seeing a lot of benefit from narrative therapies. But just a combination, not feeling like you got to have that one modality is real key and important.
I think one of the best practices that I've learned over starting addiction treatment is where you start is not where you stay. You continue to grow. Recovery is fluid. Treatment and medications change. And if I stayed where I've started 7 years ago, patients would miss out on all kinds of different treatments. And just opening our minds and challenging each other's professionally and our own, and being mindful and being aware of what we bring to the table as far as our own oppositions for treatment for patients and our own stigmas that we don't necessarily know they're there. So I think that it's important to have that fluidity and challenging each other in a constructive manner.
And I think one thing that we're talking about right now is harm reduction. The field in the past 10 years, I'm going to go back to that, has moved from an abstinence-based treatment model to harm reduction, meet the client where they are, find out what works for the client to help them make better life decisions. I know 30 years ago, whenever I got started in this field, it was like, well, if you're using, you can't come to treatment. And now it's, the outlook is progressing to the point where, okay, you drank a 6-pack instead of a case yesterday. That's good. What can we do to keep that going? And recognize all those steps that are in between full-blown addiction and total abstinence. Recognize those steps as progress and work to get the person to the place where they want to be. Because, as a clinician, my goal can always be that you're going to stop using completely and you're going to get into recovery. And my client's goal might be to stop getting DUIs. So I'm just going to drink while I'm at home. And I think we need to recognize that to keep people engaged. And I know there's a few people out there who can't believe they're hearing that come out of me. But it's true. I mean, the client's goals don't always line up with the clinicians. And I think something that the clinicians have started to become more and more aware of, and even SAMHSA is favoring harm reduction models now, is just understanding what the client wants and what can we do to keep the client safe, keep the community safe, and the people around them safe. So next question, how do approaches to treatment vary based on factors such as the type of substance used, the severity of the addiction, and individual needs? Let's go first. Yeah, we made eye contact.
I got it. I think all treatment needs to be patient-centered. It's not cookie cutter. It's not cookbook medicine. Patients don't read textbooks and their bodies don't read textbooks. So they're not necessarily going to follow that. So it's going to change from the first day you see them to the last day that you see them. And you have to be able to move and kind of, they'll keep you on your toes. I appreciate that and those challenges. And, that's okay. So we sometimes trudge it together and reach out and phone a friend and work through what we need to. But it has to change as you see them. It's not going to be the same.
I know for us in our program, we have to, there's an assessment prior to even getting there, done through our access center, and then they're assessed when they arrive to kind of see where they're at as far as the substances they're using, what level they're at and so forth. And we kind of, put them in one of our programs from there. So that's as far as, looking at the way the treatment may vary that they may receive. But then even in getting them at whatever level of care that their substance dictates still means it has to be person-centered and figure out where to go next with that person once they get there. Sometimes there's things that you'll see once they do begin to the substance begins to leave the body and they begin to detox and get through the withdrawal, that you'll see a lot of other factors pop up that you have to begin to address. So, it has to vary, it has to change with each and every person and their needs at the time. So.
Thank you. How can individuals and families identify reputable treatment programs that use evidence-based practices?
Sure. What's questioning? I think we got a little ways to go on that. I brought that up in a core grant meeting with Frankfurt. We do need a way to have a measuring stick, who is actually providing evidence-based care at the residential setting, who are maybe heavily reliant on one aspect, the spiritual aspect, which programs are a mix of staff of those with lived experience and those with the degrees outside their name. I think that is important because both play a critical role. If somebody has severe trauma, just somebody sharing their lived experience may not be able to help that person as far as they need to be helped. So I like that blend, and I would like to see some kind of scorecard out there on who is practicing, what are their recovery rates, just things like that. But I don't think we're there yet.
Yeah, I think that's a lot of that's dependent on, it's marketing. A lot of times is what people are going by, but, our curriculum that we use is based on evidence-based modalities. But I think more evidence-based for us, like Mike just kind of mentioned, is we have multiple staff members that work for us now that were patients in our program at one point. Our facility has been in London for 6 years, and there's other Recovery Works facilities in Kentucky, but we have patients that one of our staff members was the very first person to walk through that door when the doors opened as a patient. For me, that's evidence-based, right? That's showing that if we have 5 people on our staff, which we actually have more than that, but if we have 5 people that are still in recovery, that are still doing what they need to do for themselves in recovery, and they got that start in our program, that to me is evidence that something's working somewhere. So it's not just the therapeutic modality as evidence-based. A lot of times it's just what you see as a result of those people that are making it through your program.
All right. Well, okay. Then we'll move on to the next question. How can healthcare providers play a role in preventing addiction through initiatives such as screening, brief intervention, and referral to treatment?
So just not to be afraid. A lot of healthcare providers are afraid and don't have the necessary tools in their tool belt to really be able to help the patients that come in their door. As far as prevention, talking about the risk of chronic opioid prescribing and alternatives to pain management are huge. We're seeing the full repercussions of now being told that opiates have no addiction potential and the overprescribing of that. So that we're seeing the roll downhill of all of that misinformation, and thankfully getting some funding to turn around and fix that. And it's having the connection with your patients, that continuity of care to have difficult conversations, where they can really get to know you and feel comfortable about being vulnerable, talking about addiction and struggles that they have.
I thought that was a great answer. Okay. Do you guys have anything to add? Okay. Well, I'm going to come up on this is our last question. All right. Yeah, this is our last question. What steps can healthcare organizations take to integrate addiction prevention into routine care?
What we're doing at Baptist is integrating it in all of our primary care locations. trying to reduce that stigma as well. I think we're working much more closely together with the medical side of the hospital. Anytime we have the opportunity to educate, we're educating, like events like this. But I think as a healthcare system, Baptist is leading the way there in terms of the integration model and having all aspects of the care right there for the patient.
Do you have anything you want to?
I think as a healthcare system, it's an encouragement for the primary care providers to get their feet wet and get that exposure. And once you do, like, it's my favorite part of my practice. And if you asked me that 10 years ago, if I would be doing addiction treatment, it was never on the radar. So I think getting your toes wet and getting comfortable and having colleagues that you can call on and go, at the elbow or shoulder to shoulder, ask questions and kind of help you through that. I started with the core grant. I know that Grace Health is doing the core grant, and that Hazelden and Betty Ford were huge resources for us and their physicians, and they're challenging us as providers and the care that we provide and to reduce that stigma and have it available to all of our patients. We started a few years ago with just in our women's care, and then we were referring after delivery of the baby to everybody to Baptist, to the Briscoe Clinic. There was no physician, there was no family medicine treatment until I started 3 years ago. And just as a clinic, the staff has grown and changed, and the stigma is now lower. And, we have people who would never have said that Suboxone helps patients or medication assisted treatment helps patients, Vivitrol helps patients, and wasn't even on their radar as an option for treatment now come and say, if you need off, because I just had a baby. So I had a baby and it was off for 3 months. If you're going to be off for a little while, I wouldn't care to cover some of your patients and help you out. And that's not something that we would have had 3 years ago before I started. So it's those conversations and reducing stigma and access, reducing barriers to care. That's really important.
Okay, since we have some time left, I do want to give each person on the panel an opportunity to mention anything that they feel like we haven't addressed or, feel like we need to make people aware of. Do you That's a good first.
I think we covered a lot. Just, for me personally, it's our facility in London. For me, it's personal. It's not just the businesses. We've had people mention that earlier. It's not just about a paycheck, right? I'm from this area. I've seen the struggle my whole life. My whole family has gone through this disease of addiction and fought through it. So it's like, for me, I think it very personal that I'm able to go to work every day and be able to offer these services to people. And you look at the human aspect. There was a time, which has kind of been mentioned before, but when I worked primarily with adolescents, I said, because of my experience with my own family, I don't want to work with those people, because I've dealt with those people all day, every day, my whole life. So I'm not going to work in that population. When I was at Baptist, I was encouraged, not forced, but encouraged by Mike to work in the IOP program and help out there. And I learned a lot and very quickly learned that we were dealing with human beings dealing with the disease. And it changed my whole perspective on addiction and what we were working with. And it even opened my eyes to some of my own family issues. And I learned a lot from it. And I try to pass that on to my own family now and my daughters, and let them realize that we were dealing with human beings struggling with an addiction, which is, we have to look at it as a disease. And, so it is very personal for me. And I think most everybody that I know on this panel, it's the same way. It's not just a job you're going to every day. It's something where you can go in and you can make a difference. If there's one person alive today because of something I did or said, then I've done my job. Right. And I think we all have to take that perspective on it. We are doing good things to help people. Not everybody. We're not going to help everybody. We're not going to save everybody. It's not our job to save them, but it is our job to give them the tools to take back with them to help them save themselves.
I guess I could add on to that just to appreciate the small victories. but also to feel empowered anytime you hear these judgmental comments, no matter where you're at, to speak up. I think a lot of times that just gets perpetuated when people don't speak up and address it right then and there. It can be awkward sometimes, but I have confidence you can find the way to do that.
This occupation found me, which I'm just so grateful. I'd have never dreamed of working in the field of addiction, but so humbled and so blessed by it to be able to be part of so many people that's come through treatment over the years to help find a better way of life for those folks. So extremely humbled. If we can ever be a resource for anybody, please reach out. That's what we're there for. We want to be part of the solution always. So anytime Cumberland River Behavioral Health can help in any way, we're there. Okay.
I think I'm just going to resound on that. You know, Grace Health has lots of different opportunities for patients. We are growing. If there's a need, we try to meet it. And that's how we got to where we are with our addiction treatment. There was a need and we tried to meet it. We don't have all the answers, but we'll find somebody that does if we need to. So if there's anything that we can do, if I can do, you got paid providers that are scared to get started, I will do that. I'm not an expert in the field, but I will do my best to help them along. And then your patients, I'm happy to see anybody from babies to old elderly patients, anybody that they need help on and any disease process they have. I appreciate being able and honored to be able to take care of patients here.
Well, I want to thank everyone for your valuable input. I think we got some great answers to the questions, and nobody knew the questions before today. So these were not prepared responses. Just before we wrap up, I wanted to give the audience the opportunity, if you have any questions that we didn't answer or that you'd like us to answer, feel free to ask. Yeah. Okay. And I'll answer first, and if anybody has anything to add, but I really think the strong trend at the national level is harm reduction. I think that, yes, there's absolutely a place for total abstinence, and that's the background I come from. But when you read the research, when you read the information that SAMHSA is putting out, a lot of what you're reading is meet the client where they are, work towards the client's goal. And that's the opposite of what it was whenever I came into the field anyway. Worked with a lot of legal referrals, and the referral sources goal was for total abstinence for that client. So that's what we worked on. And, of course, there were a lot of people that ended up going back to jail. Marriages ending, it was mayhem. Well, not really, but, it didn't end well just because we weren't working towards the client's goal. I think that we're becoming so much more client-centered now. Harm reduction is what's being pushed at the federal level. And I really think that that's probably the trajectory that we're taking. Does anybody have anything to add?
So like when I think about the future, I'm going to say, my Disney World goal, the most magical place on earth is where we have patients who get healthcare, behavioral healthcare, and then we don't stop with just adults, because I started this delivering babies and seeing moms who just showed up with no prenatal care and they were afraid to come into the office to get care. So then in turn, those babies are affected, kids, families. We need something that encompasses everyone, where babies can get treatment, young kids can get treatment, teens can get treatment, and families heal together, not just individuals.
Just adding a little bit on that. I've seen a progression like with the court systems, the law enforcement, all those kind of things, with the Angel Initiative and some of those other things that are out there now. That's forward progress, because people were realizing that you can't incarcerate the addiction out of anybody, right? Just throwing somebody behind bars for a few months, what does that do? And we all know that there's the opportunity to acquire substances in there as well. So I see a lot of forward movement from my experience in the field so far in that direction, and that eyes opening to the harm reduction in law enforcement and judicial systems, as well as realizing that there has to be other alternatives besides just putting somebody behind bars. So.
Yeah.
The decade that's coming, you know, have that thing. And there could really be some great change ahead. We will be adaptive. You know, better.
Right. And, you know, I talked a little bit about harm reduction earlier, and if nothing else, I think taking that approach is going to keep people in treatment longer. And the longer somebody's in treatment, the more of a chance we have to help them. So we've got about 10 more minutes. Any? Huh? Yes. Thank you. Okay, if there's no other questions, thank you for the attention that you gave us and the questions, and you guys have a great rest of your day.